now. And Dr. Landguth, you have the floor. Thank you.
All right. Hello, everyone, and good afternoon, and welcome to our Global Public Health Lecture Series. My name is Erin Langeth, and I'm an Associate Professor in the School of Public and Community Health Sciences here. I am delighted to introduce Emily Coyle. Emily is a student in our doctoral program in Public Health Studies. Before joining us at Emily earned her MPH in Public Health Policy and Management at the University of Arizona. And before that, her BA in English at Michigan State University. She currently consults for the Montana Association of Healthcare Purchasers, and she has a diverse background working in public health, advocacy, and communication roles. And also during her time here at Emily has worked with Team Vaccine and led efforts to develop hospital service area maps in collaboration with Montana DPHHS as part of the initial pandemic response planning efforts for the state of Montana. And so with that, I'm going to turn it now over to Emily.
Thanks, Erin. Just a quick check, are you guys seeing my notes or my presentation view? Okay, good. Okay, well, thanks so much for the opportunity to talk to you about this, what I think is a really important issue. I want to talk a little bit about patient safety in healthcare and the relationship to public health. So I want to start off by giving you an overview of what is meant by patient safety. The World Health Organization defines it as the absence of preventable harm to a patient during the process of healthcare and reduction of risk of unnecessary harm associated with healthcare to an acceptable minimum. The Institute of Medicine defines it as the prevention of harm to patients, and the Agency for Healthcare Research and Quality expands on prevention of harm as freedom from accidental or preventable injuries produced by medical care. So the patient safety field uses the term adverse events to describe patient harm that arises as a result of medical care rather than from the underlying disease. These adverse events are, things that happen such as drug events, improper transfusions, surgical injuries and wrong side surgery, restraint-related injuries or death, falls, burns, pressure ulcers, and mistaken patient identities. These were first described by the IOM in their kind of monumental report to Err Is Human. But these adverse events are further broken down into preventable adverse events and those that are due to error or failure to apply an accepted strategy for prevention, ameliorable adverse events that, while they may not be preventable, could have been less harmful if care had been different, and adverse events that are due to negligence. So those are events that occur due to care that falls below the standards expected of clinicians in the community. And it's important to note that preventable adverse events fall under the category of error, which may or may not lead to harm. I do want to note that the AHRQ identifies additional patient safety indicators, including infections, birth-related complications, maternal morbidity and mortality, and inappropriate treatment. So I want to talk a little bit about the burden of harm in healthcare, starting with mortality. So multiple studies have found that anywhere between 10 and 12% of hospitalized patients experience adverse events, with approximately half of these events considered preventable. So there is a general consensus about the frequency of preventable harm in hospitals, but the number of deaths that directly results from these preventable adverse events is pretty controversial. Different studies produce widely varying estimates. So you can see the IOM report in '99 estimated that 44,000 to 98,000 Americans die each year from medical errors. But then, as kind of an example of how varied these estimates are, you can see it in two studies, one that was conducted in 2020 that estimated 7,150 people die per year from medical errors. And then another study that estimated 200,000 or more died due to preventable medical errors. So the controversy arises in part because the measurement of these specific adverse events is a pretty complex and evolving area. And there's really no gold standard for measuring overall safety at the institutional level. So even when you can detect an adverse event, there's difficulty in determining whether the event was preventable. I mean, oftentimes it relies on physician review of medical records or death certificates or other forms of bias that can be introduced in that process. So looking at the morbidity factors, there's this pretty powerful report that was produced in 2015. It's called Free from Harm, and it was based on an expert panel that was convened by the National Patient Safety Foundation. Some of you may recognize the name Don Berwick. He was one of the lead authors of this report and a key stakeholder in this panel. And this report provides a pretty comprehensive picture of the scope of patient harm. So before I get into that piece, the AHRQ did estimate, based on their data collection, that over 2.5 million hospital-acquired conditions occurred in US hospitals in 2017. And then back to that Free from Harm report, about 1 in 10 patients develops an adverse event during hospitalization. Half of surgeries had a medication error or adverse drug event. Over 700,000 outpatients are treated in the emergency department each year for medication-related adverse events, and 120,000 of those required hospitalization. More than 12 million patients each year experience a diagnostic error, half of which, half of which could cause harm. And then a third of Medicare patients in nursing facilities experience an adverse event. Half of those were preventable. And then, of course, there's the cost of patient harm. In 2008, medical errors cost the US $19.5 billion, but one study estimated that the economic impact is actually much higher, with maybe about $1 trillion annually when quality adjusted life years are applied to those that die. So just to give you an example, a few examples of what the specific costs are. If you were to acquire a central line associated bloodstream infection, that would add about $48,000 to your medical bill. Ventilator associated pneumonia would add $47,000. Surgical site infection could add $28,000, and a venous thromboembolism could add $17,000. And those are costs that are not just borne by the individual, they're borne by the entire healthcare system, taxpayers, purchasers of healthcare. These dollars are not small pennies. But there have been some significant improvements in patient safety. Based on the hospital-acquired conditions metric that the AHRQ tracks, from 2014 to 2017, those conditions decreased by 13%. That's 99 hospital-acquired conditions per 1,000 discharges in 2014 to 86 in 2017. And that equals about 910,000 fewer hospital-acquired conditions than if the 2014 rate had sustained. That also equates to about $7.7 billion in costs saved, and it averted 20,500 hospital-acquired condition-related patient deaths. However, not all measures improved. Pressure ulcers and UTIs did not improve overall. And then, of course, we do have new safety challenges. So while advances in technology has led to improvements, you see computerized provider order entry, which really ends up reducing a lot of prescribing errors. You see a lot more consistent tracking of medical records with electronic health records, but these also present challenges. You may have heard of alert fatigue with these electronic health records. There's the ability to apply alerts or notices to providers and physicians when they pull up a patient's record, but these occur so frequently and cover so many different reminders and screening options and notes, depending on the complexity of the patient, that it's inevitable that human error results from just overlooking or dismissing some of these. And then, of course, there's interoperability issues among electronic health record systems because they're all created by different vendors and they don't necessarily talk to each other. So I want to talk a little bit about where the progress has been made in healthcare improvements and where the progress remains to be made. So the most recent National Healthcare Quality and Disparities Report, which was published in 2020 by the AHRQ, includes patient safety measures for racial and ethnic populations, as well as insurance status, among others. These data on racial and ethnic populations show the number of patient safety measures for which different racial and ethnic populations experienced better, same, or worse quality of care compared with the reference group, which is the white population. And that's based on the most recent data year, whether it's 2014, 2016, 2017, or 2018, depending on the population. So the comparison with the white population shows a majority of patient safety indicators were either not changing or worsening for each of these groups compared with the white population. And then I just want to share real quickly, there's a specific example you may recall from the tragic death of SHALON Irving in 2017. SHALON was a lieutenant commander in the Commissioned Corps of the U.S. Public Health Service. She worked in healthcare, she held a doctorate and 2 master's degrees. But after giving birth, she had a spike in her blood pressure, swelling in her legs. She visited her healthcare providers on many occasions. She received a lot of tests, but she was ultimately sent home without adequate attention to what was going wrong. And then 3 weeks after giving birth, she collapsed in her home and died. The point of this is, no matter how educated you are or what resources you have at your disposal, nobody is immune from, from the potential of patient harm. And in particular, there are systemic racism issues that contribute to this disparity. For example, Centers for Disease Control and Prevention report that Black mothers in the US are 243% more likely than white mothers to die from pregnancy or childbirth-related causes. I share this particular topic because it's been in the media, I think, quite a bit, and it's an important one to consider when we're looking at health disparities. So I want to talk a little bit now about what can we do to advocate for ourselves and our communities and our families in regards to patient safety. So until our society and healthcare system address the underlying root causes of disparities in healthcare, such as systemic racism, lack of culturally appropriate care, and the numerous social determinants of health that impact access to healthcare, the issue of patient safety will remain a major public health issue. However, there are resources that enable individuals, families, and healthcare purchasers to have some control over the quality and safety of healthcare they receive. I want to share a brief overview of some of the different hospital-specific patient safety rating systems that are publicly available to consumers, recognizing that not one system captures everything that matters to everyone. So first, there's US News and World Report. The purpose of this is really for difficult patients. The average consumer may not want to refer to US News and World Report for the quality or safety of their care. It's really focusing on helping consumers determine which hospitals provide the best care for serious or complicated medical conditions. The next one is CMS Care Compare. This includes data on safety, mortality, readmissions, patient experience, effectiveness, timeliness of care, and efficient use of medical imaging. There's not a ton of transparency in this one. there's not a lot of variation. Also, about 90% of hospitals are shown as no different than the national average for each of these measures. When CMS also offers 5-star rating aggregation, data on safety, mortality, all those different factors that were described above. But safety only comprises about 22% of these ratings. Health grades, they publish several lists of top 50, 100, 200 hospitals for various areas of care. They run their own data analysis rather than using publicly available data. They don't collect data from hospitals. And then they also really only recognize high-performing facilities. So you may not be able to get information on every facility that you're interested in. There's vendor created ratings, such as Castlight Health and Care Checks by Quantros. These draw from claims data, Centers for Medicare and Medicaid, and then others. And really their purpose is to create tools to sell to employers and others for the purposes of supporting healthcare decisions at that system level. And then finally, my personal favorite is the Leapfrog Hospital Safety Grade and the Hospital Survey. So the Leapfrog Hospital Safety Grade is really, this is a rating system that grades hospitals based on data that is collected from the Centers for Medicare and Medicaid, the hospital survey that's also conducted by Leapfrog if it's available, and the American Hospital Association. The other piece of Leapfrog is the hospital survey. And this is voluntary self-reported quality and safety data submitted by hospitals. And I think it's over 2,500 hospitals in the United States now submit the Leapfrog Hospital Survey. And it provides a lot more measures than what you would get in Centers for Medicare and Medicaid data. Includes, maternity care and different other factors that may not necessarily be quite as common. Here's a snapshot of our own grades here in Montana. You can see that our grades range from A to C, and I will let you all take a look at that in your own time. But I really want to just conclude with a few key takeaways. First of all, despite the controversy and the number of deaths, patient safety comprises more than just mortality, and it's not guaranteed at all in the healthcare setting. We've seen significant progress over the past 2 decades, but preventable harm remains unacceptably high, with serious disparities among racial and ethnic populations. People and purchasers have choices in healthcare, and families can look to organizations such as CMS, the AHRQ, and the Leapfrog Group to determine how best to choose a safe hospital for their families. Purchasers, particularly self-funded employers, can continue to contract directly with health systems and providers that offer high-value care to ensure their employees and families receive the safest and highest quality care available. That is it. I think I'm at 19 minutes. This is a list of my references, and I just want to thank you for the opportunity. This is an important issue to me, and I'm happy to answer any questions.
Yeah, thanks, Emily. Terrific. I think we do have time for 1 or 2 questions if anyone has some questions. We'll monitor the chat as well. Okay.
Emily, I have a question for you. Can I go ahead and just ask?
Please.
Thanks. So you touched a little bit on it, but got through my head thinking it's kind of hard to pick and choose what hospital you go to, even if you know they have a bad report. Where is that information out? And especially us in Montana, we don't have many options. So how do we know what hospitals to stay away from, or what do we do to improve the trend? Well, I'll get to that question next, because I'm doing a lot with simulation training, but can you answer that question, or was I too vague? Or do you have an idea where I'm going?
Your question is now, and I went pretty fast because I feel like I had a lot of information and I didn't even scratch the surface. But in regards to how you choose a hospital, there are a lot of different ways. I've seen ratings that can show you down to specific service lines, and there's variation within health systems, right? You may have a maternity department that does really well in their safety, and you may have the cardiac department that does poorly. And it really depends. But what I've found to be just a general, I recommend that all those safety ratings and quality ratings that I shared are some that you would consult. I mean, there's not one that answers the question for everyone. I've worked closely with the Leapfrog group now for many years, and I find their approach is really comprehensive. They risk adjust, they take into consideration a lot of different measures. Their survey is super comprehensive and takes about 80 hours for quality improvement staff in a hospital to complete it, is the average. And I guess, you can look at those specific measures underneath the grade. So the grade isn't just a grade. You can actually go under and look at the specific areas, and like hospital acquired infections, falls, surgical instruments left in the body, that kind of stuff. So yeah, I just recommend checking out those different sites. And again, you're right, we don't have a lot of options in a rural state. In Missoula, we're lucky that we do have pretty safe hospitals. Across the state, nobody falls below a C, which is a good sign. I think it's just a matter of kind of being aware and asking the right questions also. If you can advocate for yourself, then you have a better chance of receiving better care if it's shown that you're a knowledgeable and engaged patient. Does that help?
That does. That helps a lot. Thanks.
Mm-hmm. Emily, there's a question in the chat from Marty.
Mm-hmm.
To what degree do these data account for the severity of the presenting conditions?
So that's a good question. And so I know that for one of the vendor specific, one of the vendors, Care Checks by Quantros, that's one of the ones that I listed in there. They tend to work more with employers, and they also work directly with hospitals on improving their systems. They do have a proprietary risk adjustment system that they use that kind of tries to compare apples to apples. So you may hear from, I remember a specific example where a university medical center complained that they receive the more difficult patients, the people with more severe conditions. They're a teaching hospital, but this particular proprietary formula allowed for the company to compare, to basically adjust based on age, comorbidity, and severity of care, so that they would be comparing based on kind of an apples to apples system. I think CMS does something similarly, and I'm not exactly sure how Leapfrog does that, but I can send you, I know I can pull up the data and send that to you also.
Great, thanks Emily, and thanks Ryan and Marty for those questions. Give you a Zoom clap and pass it over to Dr. Simmons to introduce our next speaker.
And I'm happy to introduce our second speaker today, Helen Russette. Helen is a doctoral candidate in our program. She's also a Native Children's Research Exchange Scholar and a member to the Chippewa Cree tribe. Helen is deep into her doctoral dissertation research and will be providing us with an update today of her work. And so with that, I'll pass it over to you, Helen.
Hello, Tanse, Kisakaterian, Wape Kiwisquo. That is Cree for hello. My name is White Eagle Woman, and I'll be sharing my research update with you all today that looks at family-child engagement and behavioral development among family with young children in one tribal nation. And so I'd like to acknowledge that I'm grateful to present in the Aboriginal territories of the Salish and Kalispel people, and I honor the path they have always shown us in caring for this place for generations to come. I would like to acknowledge Jeannie Christopher, the department head with Early Childhood Services, the family advocates, Rashonda, Rhoda, Michelle, and Yvette, my community advisory team, Shanley, Ashley, Michael, and Jamie, the Confederated Salish and Kootenai Tribes Leadership Group, specifically the Tribal Council and the Salish and Kootenai Culture Committees, the American Indian Alaska Native Clinical and Translational Research Program, specifically the Community Engagement Core Outreach Core Montana Site Director, Ms. Nikki Graham, and also for their funding support. And then lastly, my mentorship team, which consists of my doctoral advisory committee, Doctors Erin Simmons, Bonnie Stevens, Annie Belcourt, Paul Smith, and Tony Ward. And then in addition to faculty, Dr. Erin Languth, and lastly, my substantive mentor, Dr. Allison Barlow. So I'll briefly cover the background for my dissertation work, the specific aims. We'll look at the study tools for the current aim, and I'll share a little on a study between green space exposure and COVID-19 mortality, and we'll wrap up. So for background, methamphetamine overdoses have been on the rise over the past recent years. And the yellow line shows non-Hispanic Native American women to have the highest age-adjusted methamphetamine overdoses compared to all other demographics. And then that is followed behind non-Hispanic white women. And so what we're also seeing is that Native youth exposed to violence risk substance misuse, which often leads to unplanned pregnancies, which occur at double the rates among young Native women compared to their non-Hispanic white counterparts. And subsequently, we're seeing higher rates of neonatal opioid withdrawal syndrome among Native infants, and this is compared to their non-Hispanic white, Black, and Hispanic counterparts. And so there is a growing body of literature well established that children with prenatal substance exposure have a higher burden of both internalizing and externalizing problem behaviors compared to those without substance exposure. And in response, we know that early childhood intervention is critical to not only address developmental problem behaviors, but also to prevent problem behaviors. And one study demonstrated that Native children born to mothers with a past history of substance use actually demonstrated greater gains in social emotional behaviors after receiving a culturally congruent intervention. And that is in comparison to their counterparts that did not receive such intervention. And then also their counterparts that had mothers without a past history of substance use that did receive the intervention. And so research is warranted to investigate the effects and to quantify the effect of caregiver involvement on behavioral outcomes, particularly among children with neonatal opioid withdrawal syndrome. And as we know, Indigenous communities, Native children have been historically underrepresented in studies on personal, community, and cultural strengths. And I say this in particular to families with a history of substance misuse. And so our overall objective, for my dissertation, is to identify and measure resilience factors to assess social emotional development among families residing in a tribal nation that have children with and without prenatal substance exposure. And so for our approach, I'll be talking about my specific aims. The first focused on relationship building with our community partner. That led to identifying a qualitative study that assesses barriers and facilitators to positive family-child engagement activities. And then the third study looks at the resilience factors in social emotional development. And from the very start, we applied community-based participatory research, community-driven, and strength-based approaches to partner with our community to have in-person meetings. And those really did fuel the mixed method study design, in that we did create a small qualitative study to inform the later larger quantitative study. And so a lot has happened. So I wanted to organize based on past, present, and future. And so we have completed A1, which was relationship building with our community partner. We have requested and received several tribal nation approvals for our ongoing studies. And we have conducted and completed caregiver interviews on barriers and facilitators to positive family-child engagement. And also, we did develop and identify our tools. And so for present, as you know, COVID-19, coronavirus disease 2019 happened. It put a pause on almost all of our research, but fortunately, we were able to do a separate study on one of the resilience measures, that being the natural environment, green space. So I'll talk a little bit about that today. We are able to identify and finalize our study tools for this current study. And then next steps, we are on the cusp of recruiting participants to complete caregiver surveys for AIM3. And then we will start collecting data and perform quantitative analysis. And once we have collected the data, we'll start to share and translate study findings back to the community. Okay, so for some results. For AIM1, relationship building with our community partner, we wanted to assess the capacity for one Indigenous community to engage in epidemiological research that is centered on both a sensitive topic with a highly stigmatized population. Our two main objectives were to, again, successfully develop a research partnership with a tribal nation, and then again, share those study findings back to the community. And we applied both strength-based and CBPR approaches to this work, and those approaches, in fact, led to us creating the smaller qualitative study. And we experienced challenges and solutions. The first challenge being finding a community partner, and a solution was with Ms. Nikki Graham with the Community Engagement and Outreach Corps to provide those early introductions to communities doing similar work as our study proposal. And then we started to identify and recruit community advisory team members, which then led into several in-person meetings with the communities, which ultimately led to us partnering with early childhood services. And a second challenge was recruitment. We were concerned about indirectly identifying participants, given that we were only focused on those with a history of prenatal substance exposure. And in addition, for our solutions, we expanded eligibility criteria to include families without a history of prenatal substance exposure to maintain participant confidentiality. And we were able to identify and work with family advocates that would be present, provide transportation if needed, and they actually helped with recruiting eligible participants. And the last challenge was compensating our community partner and time. And so we were able to draft and finalize a memorandum of agreement between our university and the CSKT legal councils, which included compensation to our community partners so they could utilize those funds for services and programs. And in addition, we did secure a development award to do the relationship building activities described for AIM1. And the outcomes led to a successful study collaboration with our community partner. I felt that this also created a robust study design in that we were identifying specific activities, both that are relevant to the target population, that being families with that history of children with prenatal substance exposure. And then as part of the MOA, we did formalize a dissemination plan to share study findings back to the community. And this work is currently in review with an academic journal. And so I'll move over to AIM 2. So the overall objectives for AIM 2 were to identify barriers and facilitators to family-child engagement activities across the community, culture, outdoors, and home settings. And then secondly, to inform a future culturally sensitive and community relevant study tool to quantify those positive family-child engagement activities. And for methods, we recruited both biological parents and caregivers to children ages 0 to 3 years old that did and did not have prenatal substance exposure. We created a 34-item semi-structured interview tool that was organized by domains. And for analysis, we utilized research yarning and directed content analysis to collect unique stories and to identify common activities, barriers, and supports respectively. And then the figure to your right is just the flyer that we use for recruitment. And so for our results, we had fairly good representation among participants. The figure to your right shows number of participants by family type, and you'll see the top two, the majority were biological parents to children, both with and without prenatal substance exposure. And for common activities, barriers, and supports, we identified several activities that families participated in. For example, local powwows / celebrations, going for walks, huckleberry picking, and all families mentioned they read to their child or their child read to them or their siblings. And then for supports to do these positive family-child engagement activities, it was helpful when community and culture events were no cost. And also that with having family and friends supports and then adequate transportation. And then I forgot to mention barriers. Cost, again, was a barrier. Being able to go and dance at the local powwows does require money to put it in order to have regalia to dance. And then inclement weather was another barrier for having outdoor activities. And then again, time was a huge thing for the in-home activities. And then lastly, for the results, I did find a unique story, and I'll read the first quote here. I wish we grew up dancing. She's like, yeah, it sucks that our family grew up drinking and doing drugs. It's nice because that's not the thing anymore. We want to restore traditions and get rid of alcohol and drugs. And to me, that indicates the familial barriers to traditional practice and identity. And then the quote to the right of that goes as, they went and dug bitter roots with Head Start for the first time this year. And that meant a lot to them, but that was the first time we've ever did that. And that was actually a caregiver to a child with prenatal substance exposure. And to me, traditional practice, Head Start really highlights the community bridge to being able to have that sense of traditional practice and identity. And so these results are currently in circulation with our study authors and will submit to a journal article. Okay, so for the current study, I don't have a lot to share other than that we will be measuring both early caregiver child engagement and residential green space exposures. And we anticipate those being associated with social emotional development. And so I'll get more into the study tools for early caregiver and family child engagement and social emotional development. And the first figure I wanted to orient you to was the logic model for our tool development. And as you could see, AIM 1 really consisted of gathering evidence, relationship building, presenting the qualitative study to the Confederated Salish and Kootenai tribes leaders, for example, and one tribal council woman mentioned that Early Head Start was doing this new native language immersion program and thought that would be a good activity to measure, which of course we were able to incorporate into our study tool. We met several times with our community partner to identify relevant events, activities that they had hosted. And so we piloted this tool and we reviewed literature for activities relevant for young children. And so all of that went into the qualitative study tool. And then we further refined those results by family type just to see if there was a difference by, say, biological parents versus maybe non-biological parents to a child with and without prenatal substance exposure, which we didn't see too much of. And then we further refined those results by domain, which now comprises our early caregiver child engagement tool that includes community and culturally informed activities. And as I mentioned before, we wanted to quantify caregiver child engagement. So we include the tool as duration and amount on average that a family engages in a given activity. Okay, so to summarize this novel tool, it is a survey. It's intended for to be used for children 0 to 3 years old. The caregiver, which includes the biological parent, does complete the survey and it takes about 20 minutes. And we are looking at those activities across 4 domains, and we do include demographics. And this is more exploratory. We want to determine how much and what type of family-child engagement activities might be associated with child development. And this is a continuous scoring where we anticipate a dose-response association. And the social emotional tool that we're using is called the Brief Infant Toddler Social and Emotional Assessment, BITSI for short. And this is a screener survey. Its specific age range is 12 to 35 months and 30 days old. It can be completed by a caregiver or a teacher. It's very short, 5 to 7 minutes to complete. It includes a problem, 2 types of behaviors for social emotional problems and social emotional competencies. So for problems, that includes externalizing, internalizing, dysregulation, and for competency, that includes social emotional abilities such as sustained attention, peer relations, empathy, and high total problem scores at or above the 75th percentile, or low competency scores at or below the 15th percentile indicate potential problems, delays, or deficits. And if a family does score in one of these ranges, we will share the study findings back with a participant and recommend their toddler receive more in-depth social emotional evaluation. And this tool is very easy to administer. It ranges from not true to rarely to very true to very often for activities. Okay, so we're going to switch a little bit over to GreenSpace, the GreenSpace study. As I mentioned, COVID-19 happened, and some of the predictors for COVID-19 mortality include chronic diseases such as hypertension, diabetes, coronary heart disease, being immunocompromised, having abnormal immunity, and being older in age. And then some social environment and demographic predictors include poor air quality, being low income, having Medicaid, Black Americans, and overcrowding in the home. And this is not an exhaustive list. These were just some select predictors I wanted to share with you all today. And this figure is a little difficult to see, but these are the multiple pathways for physiological outcomes that are associated with exposure to green space, in other words, the natural environment. And because I was already looking at green space exposure as a resilience factor for children with prenatal substance exposure, I had come across a plethora of numerous pathways, numerous positive outcomes. And thinking about COVID-19, climate change came to mind, in which we see ecosystem damage that impacts microbial ecology, which leads to infectious disease outbreak. And again, there's these multiple pathways that the natural environment can impact health. And so you'll see with the darker shaded arrows, you often will see reduced cardiovascular and all-cause mortality, showing fairly strong evidence. And thinking about immunocompromised individuals, we do know that early and prolonged green space exposure promotes improved immunoregulation. And a lot of the human outcomes are also the risk factors to COVID-19 mortality. So we set out to study a potential association. And we did find an association, but I would like to orient you to the maps on the left. The map in the top left corner is leaf area index deciles, and that quantifies green space by counting the number of green leafy area layers. And so the denser greenness will often indicate the more presence of trees. And the map below that is the COVID-19 case fatality per 100 population, again, organized by those deciles. And the figure to your right is the adjusted mortality rate ratio values that use a negative binomial regression coefficients of COVID-19 death rates and exposure to green space by decile. And these were adjusted for education, overcrowding in the homes, Medicaid, ages 65 and older, Black and Native American races, physical inactivity, and neighbor COVID-19 mortality average. And so our novel analysis of green space exposure and COVID-19 mortality in the US has demonstrated that increased green space exposure is associated with reduced risk of COVID-19 mortality, particularly in the top 3 LAI deciles compared to LAI decile 1. And these results are currently in review in an academic journal. Okay, so we are going to wrap up. And just a summary, we are seeing that Native infants are experiencing high rates of prenatal substance exposure. And with some of the studies, they do indicate that early childhood intervention is critical to occur within and in collaboration with tribal nations. And I will be measuring as next steps, green space and caregiver child engagement as resilience factors against behavioral problems. And I will continue to collaborate with tribal nations. So here are funding supports, references, and I'd just like to thank you for your time.
Thanks very much, Helen. Great presentation. Looks like we have maybe time for just one question if anyone has a question.
Helen, I've got a question for you. If you, just looking at your green space analysis and tying back to some of your other work, would it be possible to conduct that same analysis in counties that overlap with American Indian reservation communities, and to try and see if this is a particular, you know, if this impact is sort of, I don't know, more pronounced in those communities?
I think I heard you right. If we could replicate the way we measured green space exposure for COVID-19 among tribal nations, tribal reservations.
Yeah, or just include that as a factor in the overall model.
I think so. That would definitely be a conversation I would like to have with the mentor from that project, Dr. Erin Languth.
Yeah, great question, great idea. And it looks like we're just about out of time. And I think Kimber maybe just has one additional.
Right.
You're muted, Kimber.
Kimber, you're not showing as muted, but we're not hearing you on our end. Do you want me to make that announcement for you?
Now, can you hear me?
Now we can hear you. Thank you.
Oh, good. Okay, sorry about that. I just wanted to say thank you to Erin Simmons and Erin Langdeth and your students, Emily and Helen. That was fascinating and great updates on your work. Next week's speaker has had to cancel and our two backup speakers have also become unavailable. So we have a week off next week from our speaker series, which means that our final 2 weeks of the semester, the weeks of April 12th and April 19th, are our two final speaker series installations. And those are going to be the APE presentations by our MPH students who completed their APEs this semester. So we'll be looking forward to the first of those 2 weeks of presentations on Monday, April 12th at 2 p.m. So look forward to seeing everybody there. And thanks again to today's speaker. That's it for me.